All right. Well, thank you everyone for joining us this morning. I have the pleasure of introducing Dr. Walter Sussman. He is board certified in physical medicine and rehabilitation, as well as sports medicine. He completed both his residency and fellowship at Emory University. He now practices outside of Boston and helped to found Boston Sports and Biologics. He also serves as an assistant clinical professor for orthopedics and rehabilitation for Tufts University School of Medicine. He also has co-authored a book on the Atlas of Interventional Orthopedics. And then lastly, he's also an instructor and board member for the Interventional Orthobiologic Foundation, whose mission is to educate physicians on simple to advanced image-guided injection skills through hands-on cadaveric courses. And today he's going to be discussing a case and protocol for insertional Achilles tendinopathy.
Share my slides with you guys. All right, so I appreciate the invite and the opportunity to do this. We see a lot of this in our clinic, and these can be challenging cases. So as far as disclosures, I am a board member in Interventional Orthobiologic Foundation, does a lot of hands-on training for ultrasound and fluoroscopic guided procedures. And then I serve as a consultant for a couple other companies. This is our textbook, so I do get royalties from that. So we'll follow the similar progression through this case and talk about some of the pathology. So this is kind of classic for a patient with insertional Achilles tendinopathy. A lot of times this is kind of this chronic, progressive, insidious case. This patient had tried a lot of conservative management before he came to our clinic, including physical therapy and immobilization. He had a number of shockwave treatments and a couple of PRP injections by his local podiatrist. And he really localized the pain to the insertional Achilles tendon. It was initially present with running, and then as it progressed, he started having more pain throughout the day. And it really worsened or lingered after activity. And so when we examined him, he had normal alignment. He had that classic pump bump and tenderness over the insertional Achilles tendon. He had full range of motion. He had normal strength, normal sensation, and the calcaneal squeeze test was negative. The palpation and tenderness and localizing where the pain is coming from is really kind of important in my exam. This is a study looking at mid-substance Achilles tendon pathology. So it doesn't 100% apply to insertional, but there are some lessons to be taken from this study. And so they looked at different tests, whether subjective palpation or these loading tests. And what's interesting is palpation is actually a really good test. If they hurt there and push on it and it hurts, that can really help localize and confirm the diagnosis. And so we're going to really divide, the Achilles pathology into mid-substance pathology and insertional pathology. And they're really two distinct disorders, and treatment should be targeted towards each of these. And so, you never want to assume anything. We want to come into these cases with a broad differential, looking at the tendons in that area, the potential bursas, the bony abnormality, adjacent structures, including the neurovasculature, the joints, and then above and below the soleus, the plantar fascia. And so this patient already had these standard weight-bearing radiographs. And what you can see here is that there is a few things going on. And as far as terminology, the Haglund deformity is not the same thing as a spur. And so you can see in the bottom left, the Haglund is this prominence of the posterior superior calcaneal calcaneus. Well, that spur is really at that insertion of the Achilles tendon. And we want to specify, is it a calcaneus spur at the plantar fascia insertion or the Achilles? Now, Haglund syndrome is different. That's a triad of not only the bony prominence, but also the bursa being inflamed and the insertional Achilles tendon. And when we see insertional Achilles tendinopathy, about a quarter of those cases will have an associated bony abnormality. And where this becomes relevant is that as that bone projects upwards, you can imagine as the ankle is dorsiflexed, that bone can rock into the insertional Achilles tendon. Radiographs are a useful tool, but there have been a lot of different angles and measurements that have been described. And there's no clear-cut consensus on which of these is the best to confirm that diagnosis. But here we can see he has a Haglund bump, so the calcaneus protrudes upwards and backwards. He's got a small calcification and also an enthesiophyte. And so we evaluated him with ultrasound at that same visit. And this is the AMSSM protocol. The AIUM has a protocol as well. So, ESSR has a protocol. So there's different ways of approaching this, but we'll kind of walk through the required structures for the AMSSM scanning protocol. And we started looking at the medial and lateral gastroc and the soleus. You want to get short axis and long axis views of these structures. What was interesting about his is that his had some thickening of this aponeurosis, and the medial gastroc had this retraction of these fascicles. He wasn't tender over this area, so it likely wasn't a new injury, but sometimes these abnormalities can persist. And you know, if you dig, maybe they remember a previous pop or a strain. Sometimes you can get larger defects in that aponeurosis. And so there's a grading scale where what we showed in his slide would have been more consistent with a strain, where some of those fibers had started to pull off, you know, some thickening of the aponeurosis. This is a partial tear. So this is another patient, but you can see that between the medial head of the gastroc and the soleus, there's this dark collection, this hematoma that had formed. There's some retraction of some of the fibers as well. And you can also see larger tears where there's where the medial gastroc and the soleus have separated, and there's a larger hematoma. The next structure that we want to look at is the Achilles tendon. And so most of our ultrasounds, you know, you have to take these, you know, it's a long tendon, so you have to take these small little views and work our way down. Some of the systems will have these panoramic imaging options. And so this is a ultrasound of my partner, Dr. Latska, who ruptured his Achilles. And these are useful for pre-surgical planning. A lot of our surgeons will ask where exactly the rupture was so that they can plan their incision above the calcaneus. And here you can see this is fairly close to the myotendinous junction. But if we don't have that luxury, we're piecing together these views. And so you'll see the Achilles tendon, you'll see the soleus. Deep to that is the FHL. Kager's fat pad sits deep to the Achilles tendon. And then you can see the Achilles tendon inserting on the calcaneus. And this patient had a number of different things going on at this insertional Achilles tendon. And so you can see in the middle picture, there's this retrocalcaneal bursitis. So there's fluid there. And then there's some disruption of the deep fibers of the Achilles tendon. So you can see this interstitial tear. As we work down towards the bony attachment, these are a couple different views at that insertion, and you can see the enthesiophyte. There's prominence of that retrocalcaneal prominence, and there's that intratendinous calcification that we saw in his x-ray as well. Short axis views can be helpful. These are some companion cases looking at other patients with insertional pathology. And so when you have multiple different calcifications, you can see how much those calcifications, how much space those occupy in the tendon. You can see how dense they are, you know, how much acoustic shadowing they create. And that can help differentiate between, are these softer calcifications, something that may respond to a barbotage, or these denser ossific structures that may not respond as well to some of the the traditional barbotage approaches or fenestration approaches that we'd use. I always think of ultrasound as an extension of my exam too. So, trying to figure out exactly where they're painful is important. Again, going back to that previous study. And so are they painful as you palpate along the tendon? Maybe that interstitial tear is really where the majority of the symptoms are coming from. Is it deep to the tendon, where that retrocalcaneal bursa sits, and that Haglund bump? Or is it right over that enthesiophyte? And so switching back and forth between our ultrasound images and palpation can really help define exactly what is symptomatic, and that will help shape our treatment as well. Going back to our scanning protocol, the other structure that we look at in this area is the plantaris. This requires multiple different views. The majority of the pathology that we see in the plantaris happens at that myotendinous junction, so higher up in the calf. And as you trace it down, it becomes tendinous and harder to follow. There are various different paths it can take in relation to the Achilles tendon. So sometimes it's a little more forward. Sometimes it's really adjacent to the tendon. There have been a number of studies looking at the plantaris tendon as a potential source of pain, in a lot of these chronic mid-substance Achilles tendon cases that have been fairly recalcitrant to tendon. So Alfredson's done some work where he's released the plantaris tendon along with some of the scraping procedures. But as we get down into that insertional areas, it can be fairly hard to track. Here on the left, you can see it's hard to see it medial to the Achilles tendon, but with some adjustment to the probe, you can see that definition of the tendon. And then this is a companion case. We didn't look at the posterior bony structures in our patient. These can be seen. You have to do some adjustment to the frequency and to the gain, adjust your focal zone to really optimize that picture. But you can see these posterior structures. You can see them, so you can guide injections into them with dynamic testing. Sometimes you can see fluid or impingement of some of these bony structures as well. But in this case, he had pain with palpation over the calcaneal spur. He had pain with palpating along the tendon, and he had pain deep to the tendon. So he kind of had the trifecta of what we typically see with a Haglund syndrome, with tendon involvement, bursal involvement, and then he also had the enthesiophyte. And so these are other companion cases because you'll see a whole wide variety of pathology in this area. And again, trying to figure out, is this mostly tendon? Is this bony involvement? Are there intratendinous deposits? All these will guide our treatment. So, really kind of focusing on exactly what's going on at that area with your exam and your ultrasound will be helpful in kind of figuring out what the next steps are in these patients. So in this case, there's some interstitial tearing. A lot of times with Haglund syndrome, the interstitial tearing will involve the deeper fibers. There's a little bit of fluid in that retrocalcaneal bursa, and you can see a prominence of that posterior superior calcaneus. Here you can see that there's that interstitial tear as well, but this tracks down to that enthesiophyte. There's no retroachilles bursitis in this case. And this patient had actually had surgery to remove the calcaneal protuberance, but was still symptomatic because the interstitial pathology hadn't been addressed. This case, there's a little prominence of the superior posterior calcaneus, and then there's also this intratendinous calcification. There is some tendinopathic changes, but not a clear tear in this case. And here again, tendon thickening, intratendinous calcification. A lot of times we see these go hand in hand. What's interesting here is you can see some cortical erosion. This patient had a couple cortisone injections with a podiatrist before they had seen us. And so after the ultrasound, after an evaluation, our working diagnosis was that this was Achilles tendinopathy, retrocalcaneal bursitis, and Haglund deformity. And in this case, we elected to remove the calcaneal prominence with the percutaneous osteotomy device. In this case, we used 10x. We also addressed that intratendinous calcification. So you can see in the left, there's a calcification. You can see that has decreased in size. And then we also trimmed off the part of the spur, part of the enthesiophyte. And so these are the incisions in the bottom right. This is a picture of the following day, because we also use biologics to treat the tendon. And so our sample report, I have the top really small. This is more for reference for you guys. But the mid substance appeared normal in caliber and echo texture. The insertional Achilles had the hypocoque changes into thickening, which was consistent with tendinopathy. And then there was also disruption of those deep fibers, which we see with a partial interstitial tear. There's prominence of calcaneal protuberance, the bursitis, retrocalcaneal bursitis, and Achilles tendon changes that we see with Haglund syndrome. There's also the Achilles enthesiophyte without the retro-Achilles bursitis, a small hyperechoic density without acoustic shadowing, consistent with the calcification. If you see more significant acoustic shadowing, that may signify that it's either a denser calcification or an ossification in the tendon. So there's a distinction. And then we also saw that subtle thickening of the aponeurosis at the medial gastroc, but that wasn't tender, which suggests that this may be more of a chronic problem. So I think, the big take homes, when you look at this area is you really know the anatomy, understand the pathology. I think that's true no matter where we're assessing a patient with ultrasound. I think history is really big, in terms of guiding us, as well as our physical exam, and ultrasound is really an extension of that. In general, radiographic findings have a low predictive value for Haglund syndrome and a high false negative rate. So, again, relying on our other tools besides just making a decision on plain films. But sometimes these can be fairly subtle, so Haglund disease, we don't really have clear definition of radiographic definitions where there's clear consensus. And so, putting together all these tools that we have, our exam, our ultrasound, to kind of figure out exactly what's going on and what next steps would be with this patient. So.
Awesome. Well, thank you so much, Walter, there for the talk. Really appreciate it, especially going into great detail with all the pathology for insertional Achilles tendinopathy cases. Kind of two things I would bring up definitely with some of the kind of scanning techniques and protocols is that, as you had mentioned, sometimes differentiating these cases of tendinosis versus partial or even complete tears can be really difficult. And so in some of those cases, I think it's always important to kind of add in some dynamic imaging as well too. And so obviously just going into, plantar dorsiflexion, sometimes that can make it a little bit more apparent than if there truly is going to be a partial tear or even complete tearing, just because sometimes those can even be a little bit difficult to differentiate. So adding in that dynamic imaging, especially early on, I think can be helpful. Another thing that you had mentioned as far as some of the hypervascularity would be just, adding in, color Doppler as well too, just because in some of these insertional cases, there may be an inflammatory enthesiopathy process going on as well too. And that will be really helpful to kind of differentiate, is this just more of a kind of degenerative cascade that's been going on with the Achilles tendon, or is this truly an inflammatory process? Just because obviously with that, you're going to get more vascular flow, not only going to that tendon, but also potentially to the bursa as well too. And then lastly, one thing that you had mentioned as well too, when you're looking at tears of these, especially trying to get a broad field of this, which is going to be helpful for surgical planning purposes, which can be difficult because of the length of the tendon, but extremely important to provide the information. So, but I'll also go ahead and open it up for any kind of questions or comments from anyone else that's on.
Yeah, I have as usual, I guess, have a few comments. Or Walter, nice job. I mean, you hit all the highlights and important ultrasound findings. I'm probably just going to restate a couple things in a different way. So I always think of distal Achilles problems as very difficult because, as you mentioned, because one is they tend, in my experience, they often get worse with physical therapy and aggressive stretching, even though oftentimes flexibility is an issue. And then two is, the standard surgical procedure, the detachment reattachment procedure has a long recovery, and oftentimes patients are reluctant. And so our toolbox has expanded as alternatives to an open surgical procedure, and therefore the role of ultrasound has become much more important, because an ultrasound has better resolution than MR, and we can get down to the fine details, which in turn can direct these non-operative or not open procedures. And I think, Walter, as you alluded to, that we don't need to address every single thing at the distal Achilles tendon, but what we want to address is the pain generators. My protocol is fairly the same. I do add into the medial tarsal tunnel. I just do a short axis of the medial tarsal tunnel for a number of reasons. One is at times it can be a pain generator in the distal Achilles region. Two, it nicely adds joints. You could do the posterior ankle joint, which works too, but the short axis of the medial tarsal tunnel allows me to get everything I need into the criteria for a complete exam. When I do these exams, and I think most of us that do a lot of ultrasound see this quite a bit, I basically have a systematic approach in my evaluation of all the pathology of the distal Achilles tendon. And I start superficial to deep. So superficial, we have the adventitial bursa, which can be a pain generator. From there, deep to the adventitial bursa, we have the distal Achilles peritoneum. And I think you're going to find that there are varying degrees of thickness as well as vascularity of the peritoneum. And if I feel this is a major pain generator, this will be addressed if I'm doing a procedure. Deep to the peritoneum will be the Achilles tendon itself, with different degrees of interstitial tearing, thickness, vascularity, intrasubstance calcifications. And just to highlight a point that Steve made is I also do a dynamic exam, because what I found is that there will be some people that have a very large undersurface tear of the Achilles tendon. In fact, sometimes it feels like it's holding on by a thread, which may influence whether I choose to do a procedure or not. And this oftentimes, if you have a little tension on the Achilles tendon or a slight dorsiflexion, you'll miss this. From there, deep to the Achilles tendon itself, then, as again, Walter, you outlined it really well, I look at the morphology of the bone, the enthesiophyte, the posterior calcaneal projection for varying degrees of, Haglund's deformity, and then deep to that is the retrocalcaneal bursa. So I have a nice systematic approach going from superficial to deep. And again, Walter, as you mentioned, this is a heterogeneous disorder. And so, for example, just this week, I saw someone whose pain is limited to the superficial adventitial bursa, whereas other people can have large tears of the deep surface of the Achilles tendon, retrocalcaneal bursopathy, along with it, a huge enthesiophyte. And those are a little bit different, and the treatment, in fact, is different. So, you outlined that well. And so ultrasound has really been a game changer in terms of understanding the problem and defining the heterogeneity of this disorder.
Yeah, I think, the piece to add, is, a lot of times we're working with our surgical colleagues too, so, we often we'll do a percutaneous approach, but there's an endoscopic approach to trim down that Haglund deformity. And if there's tendon involvement or not tendon involvement, can be very helpful for the patient and the surgeon to know, because that's going to dictate recovery. And, patients where they just have the prominence, a lot of times they're returning much faster than people who also have tendon pathology. And we have a lot of tools now with shockwave and biologics and, aggressive therapy on the back end, but it's helpful to know on the front end, what they're heading into. Because most patients are trying to avoid the bigger surgery, the open detachment, the 3 months in a boot, and potentially up to a year of recovery afterwards.
So, Walter, are your surgeons using ultrasound as the first line advanced imaging in these now?
Some of them are, some of them we're working very closely with. A lot of them still rely on MRI. We don't work with everybody in the community, but there are some of the younger surgeons who are valuing this and the prognostic, or the ability to prognosticate, after the surgery.
Mm-hmm. Nice.
Walter, I was going to bring up, there was one question that we got from Thomas. I think we had touched on it a little bit, but he was just kind of bringing up the utility of the Doppler as far as hypervascularity. I guess the main thing would be kind of how you use that. I know it's kind of changed, over the years on how people kind of view hypervascularity, whether that is part of the kind of pain generator process, but kind of how do you use that, for your protocol?
Yeah, I find it more useful for more mid-substance pathology, in general. That, as well as looking at the interface between the Kager fat pad and the tendon, and if it's really bright, the fat pad in that space, and you'll see even focal areas of hyperechogenicity in the fat pad. And in those cases, sometimes we'll start with either a high volume injection in that fascial plane between the tendon and the fat pad, or a scraping procedure before considering biologics and some of the cash-based procedures for some of the mid-substance pathology. So I use the Doppler in that situation, as well as looking at the adjacent fat pad to make some decisions on management.
I actually think that, and other people chime in on this, I think first of all, just a quick note about Doppler is if the patient is lying prone, make sure that the Achilles is relaxed, because if there's any tension on it, you'll get a false negative. But I find it helpful to help define what are the major pain generators. So if I see the peritoneum really light up with the superficial adventitial bursa, I'm more confident that those are important pain generators. It's unusual to see a distal Achilles tendon problem without some change to the tendon. And just to get more confidence that some of the mild changes may be pain generators, I think that Doppler is helpful. So in this patient that I just saw this week, who, really I thought it was more just a superficial adventitial bursa, there was a little bit of Doppler activity within the tendon itself. And so I do believe then that the tendon is part of the process. I don't know, other people chime in if they felt the same way, that Doppler, helps them, at least as it plays a role in understanding the pain generators.
Yeah, can I make a quick comment? This is Ryan. Yeah, so I agree with you, Doug. I think my Doppler button probably wears out more quickly than anything on the ultrasound machine, because my finger is on that and I'm turning that on and off, on and off, on and off on every single structure. I think it just helps me diagnostically. So I agree. I'm using that quite a bit, and I think it helps me become more comfortable in determining whether or not a pathologic structure is symptomatic. I just have maybe three other quick points to make. Well, like Doug and Steve said, that was awesome. So we appreciate you giving that talk. My protocol is similar to yours. The only thing, you may have mentioned this, and I apologize if I missed it, but I always include the sural nerve here for evaluation in this region, not only from a diagnostic perspective, but also when I'm planning any intervention. It can sometimes get in the way, so I add that. The other point to make is that not all Haglunds, and I think you alluded to this previously, but not all Haglunds and deformities and not all enthesophytes are symptomatic. And so, we see plenty of asymptomatic Haglund's deformities. And if I don't see any deep tendon on ultrasound, if I don't see any deep tendon changes or ventral tendon changes or pathology, then I'm less convinced that Haglund's is truly symptomatic. Like I think everybody has mentioned so far, using dynamic imaging can be helpful as well. And similarly, these enthesophytes, not all enthesophytes are symptomatic. And what I'm looking for around an enthesophyte is obviously tendon pathology or pathologic changes. I'm looking for surrounding soft tissue edema and surrounding soft tissue hyperemia, or Doppler as well. And that kind of helps clue me in that the enthesophyte is symptomatic. If I don't see any of those changes, even if they have what I call a large shelf enthesophyte, which kind of spans the entire width of the tendon, if I don't see tendon changes or surrounding soft tissue or retro Achilles bursal changes superficially, I'm not convinced that that's a symptomatic structure, and I'm probably not touching that procedurally. So just a couple comments to make.
Yeah.
The other thing that we often use, is anesthetic, and these ultrasound guided targeted injections, and putting in 2 cc's of lidocaine into the retrocalcaneal bursa and have them run around the parking lot, often will kind of confirm, the diagnosis if that's on our list, if, we're trying to tease it apart. The other thing that's helpful is watching the fluid go in. Those undersurface tears, can be surprisingly big and open up with a little challenge of anesthetic. So that can also be helpful as we're trying to piece together what the pain generator is.
Yeah, I mean, that's a great point. Ryan, just back to your point just for a second. It's my impression that when you have an enthesiophyte, that the actual pain generator is the superficial adventitial bursa and the peritoneum that's probably somehow activated by the enthesiophyte itself.
I agree. I don't think the actual enthesophyte itself is symptomatic. I think it is a symptom producer. I think it is causing symptoms within, if it's like you mentioned, a superficial enthesophyte within the retro Achilles bursa. I completely agree with that. I don't think the actual calcific enthesophyte itself is likely the pain generator. I think it's the somewhat mass effect on the soft tissue around it.
And history is really helpful in those cases, right? If they only have pain with certain shoes, it very well could be that enthesiophyte and that bursa superficial to it. Whereas activity-based pain, that tends to be the tendon. And if they have the pain without wearing shoes or anything pushing against the enthesiophyte, it's again less likely the enthesiophyte. It's probably the tendon or the deeper structures.
Walter, this is Brennan. That was a great talk. Thanks, and Doug and Ryan and Steve, thanks for all your comments here. One of the things I'll say is I think this area of the body more than anything highlights how important it is to do a physical examination along with your diagnostic ultrasound. And a lot of us probably get referrals for diagnostic ultrasound only in these sorts of cases, even if we're not clinically managing these patients. And I still think even in that scenario, if you're not going to be making the treatment decisions with that patient, you should still be examining them and trying to provide some context to what you are, scanning and reporting, so that pressure phenomenon. Do you have pain in your Achilles when you walk barefoot around the house? If the answer is no, you can be really looking at that posterior superficial soft tissue structures related to that enthesophyte. Oh, I have pain primarily when I go, upstairs. Well, you can think of that Haglund, pushing into the retrocalcaneal bursa, undersurface Achilles. And so using that kind of history, clinical examination and context in the setting of your ultrasound, where then you can, find the different structures that are seemingly painful, I think is a really helpful portion of, why ultrasound is going to provide some context. Now, I will say I've had some patients that have had substantial bone marrow edema along with these problems, and have a lot of bony pain even in the absence of a stress fracture. And so I think there is some complementary role of getting some cross-sectional imaging with some of these patients as well. Do you need to offload them for a little while and try and calm down that marrow edema?
And that last bit, there are studies looking at trying to prognosticate how well somebody will do with removing that, doing a Haglund surgery. And when you see bone marrow edema on an MRI, those patients tend to do better than when you don't see bone marrow edema in that area.
All right, well, we'll check anyone else with any other kind of questions or comments. Otherwise, I think we had a really good discussion here at the end.
Yeah.
All right, well, thanks again so much, Walter. And then just another reminder that in 2 weeks, we will have the pleasure of Dr. Doug Hoffman giving us a talk on the plantar foot and plantar fibromatosis in 2 weeks to kind of finish out the attending series for the year.
Thank you, guys.